the webinar is titled Unmasking the Silent Epidemic, Addressing the Global Surge of Type 2 Diabetes. So today we have two experts who will discuss on how we could improve health systems, better address diabetes and other NCDs. But before we start, we will have a welcome remarks, of course, from our director, Doc Dodo Banson.
Thanks, Mitch, and good morning, everyone. First of all, allow me to thank an old colleague from the World Bank, Abdo Yazbeck. He has been in the WBI. That's where I first met him, and then has become manager of health, nutrition, and population in two areas in the World Bank. And now, of course, he's an expert, global expert, looking at health systems. So he has he'll be presenting this wonderful work in a sense. Criticism, if I would describe it, Abdo, on how health experts have missed in addressing and controlling diabetes. And this will be followed after Q&A with Abdo on Mel Santillan. Mel Santillan is in charge of the benefits of the Philippine Health Insurance Corporation, or what is known as PhilHealth in the Philippines. She'll be talking about the things PhilHealth is doing to contribute to address diabetes. So maybe Abdo, when Mel finish, which will be after the Q&A, you could also give some free consulting advice to PhilHealth on how they can better improve what they're doing in addressing diabetes in the Philippines. And of course, that will also guide other developing member countries, which we're ADB is also supporting. So over the floor to you, Mitch, Abdo. And welcome, by
Yes,
the way, to
Doc.
everyone who is here at
Yes.
9 a.m. Okay.
Yes, welcome everyone. I know it's very early. So as Doc Dodo has mentioned, our first speaker, he's a retired World Bank lead health economist and manager. He's currently an associate editor of health systems and reform and faculty at the Johns Hopkins University, Bloomberg School of Public Health. He is working as an independent consultant supporting various international organizations, including USAID, World Bank, WHO, Global Fund, and of course ADB. So today he will be delving into the systemic failures that have contributed to the rise of type 2 diabetes, including shortcomings in early detection, understanding lifestyle drivers, and policy missteps that exacerbate the problem. So, Abdo, the floor is yours. Thank you.
Thank you for the kind introduction. Let me see if I can share the slides. I think I can. So here we go. Uh, Turn it full. Thank you very much. It's quite early in Manila. It's quite late where I am in Washington, D.C. So hopefully I'll keep my energy up throughout. So basically, the title is the title of a paper I co-authored with two colleagues, Shanam Nguyen, a Vietnamese physician, and Maria Luisa Escobar, a Colombian health economist, like me, retired from the World Bank. It's part of 5 papers I've been working on for a few years. This is the first one. It got published. The second was an editorial that got published. We have 2 more that were accepted. We're going through the process. This third one is of interest to you because it's about development assistance and how development assistance, which includes the ADB, can become much more effective in tackling NCDs using the lens of type 2 diabetes. A fourth paper, which was accepted with Agnès Souka and Sylvestre Gaudin, talking about market failures and collective failures in using WHO's Common Goods for Health approach. And I've almost finished writing a fifth paper with a couple of colleagues on how technology can make a difference. So as these papers come out, I'm happy to send them to Dodo to share them with you. The presentation outline is going to be fairly straightforward. First, I've worked in public health now for 30 years. We always start by telling you a sad story. So the sad story of type 2 diabetes. Then just one slide on pathophysiology. I know most physicians hate pathophysiology. It's boring, it's complicated, but it's absolutely critical for us to understand what causes type 2 diabetes, because it'll tell us where the mistakes have been. And Dodo's correct. This paper is a critique of public health. It's a critique of global health. And so it's important to understand the pathophysiology. Then the critique, which is going to be the bulk of the paper, the 3 failures: failures in early identification, failure in clear communication of the drivers, and the fact that we actually subsidize the disease. And just give you a little hint about some of the health systems answers, but some of that is coming in the papers I mentioned earlier that are coming up. So let's start with the sad story. This is the picture of, um, you know, the US data. Um, and you can look at data in almost every country in the world that collects this data. This is, in this case, percentage of population and the number of people with diabetes. And the story is quite depressing. It's growing fast, which tells me a few things. One, this cannot be genetic. Genetics don't move in a 10, 20-year period. Genetics take 100 years to adapt. So this is something epigenetic. This is environmental. The second thing it tells me is you cannot explain it by aging, because this is moving much faster than aging. So that's sort of starting to get to think about these things. Um, WHO calls it a disaster. And the last major document WHO put out was in 2018, and they put out some pretty depressing numbers. The fact that type 2 diabetes has quadrupled in 34 years should alarm everybody. No disease should change this fast, this aggressively. Um, and it's growing everywhere, low and middle income countries as well as high income countries. So it's growing faster in low and middle income countries. It's a pretty horrible disease because it causes considerable suffering. It's a major cause of blindness, kidney failure, heart attacks, strokes, lower limb amputations. So this is a terrible disease that's growing everywhere. Data from the International Diabetes Foundation, from their Diabetes Atlas, which is probably the best global data on type 2 diabetes. And they collect every 10 years. So the last year was 2021, and they project forward based on the growth rate. And it's looking bad everywhere. It's growing fast in some places. I wanted to share this slide because I'm going to, in a minute, jump to the difference between what's called type 1 and type 2 diabetes. Type 1 is what used to be called um, juvenile diabetes. It's the kind of diabetes that happens for young, very young people. And if you look at the data, this is again from the US over a 10-year period, there's no change. There's some genetic variations. The top line is for whites in the US, the bottom line is for Native Americans, and it's steady across the 10-year period. But you look at the slide, the B chart, the one to the right, and it tells you a completely different story. First of all, this used to be called adult onset diabetes. This slide showed us the data in the US for 10 to 19-year-olds. These are not adults. And it is growing in large parts of the population, and it's growing differently. And I'm going to get ahead of the game and tell you the reason is these two populations is growing the fastest, Native Americans in the US and Black Americans in the US, non-Hispanic Blacks. It's because of the food environment. It's because of the food that they have access to. And so it's a problem, and it's a problem that's growing fast. And of course, I'm an economist, so I have to tell you the cost side of the story. It's a problem that's causing considerable damage to budgets as well. There's a book called Metabolical, and it calculated the cost in 1 year in the US, 2020, of type 2 diabetes treatments, medicines, monitoring treatments, and it came up to 350 billion US dollars. That's 10% of everything spent on health in a country that spends more than any other country in the world. WHO thinks it's actually higher. They estimate 15% of health budgets worldwide are spent on diabetes-related illnesses. So this is the pathophysiology slide, and I wanted to just walk you very briefly through it. It's important for us to understand what is the cause of this horrible disease. I don't know if you can see my cursor here, but it's basically the driver is what we eat. There are smaller drivers I have at the bottom. Lack of exercise, level of stress, and limited sleep are small drivers. The big drivers are what we eat. Type 2 diabetes is a nutritional disease, and it's a specific nutritional disease that's linked to carbohydrates. In this slide, I tried to summarize two pathways to diabetes. Um, and the literature is quite clear that there are two ways they see diabetes developing, and it tends to be starting from what we eat. If we eat a lot of fruit, specifically fruit juices, when we take the fiber out and we give kids and ourselves a lot of juices, we are overloading ourselves with fructose. Fructose is half the sugar. It's the sweet part of sugar. The problem with fructose is that, like alcohol, it can only be metabolized by the liver. And so what happens is the liver is suddenly overloaded by too much fructose, and it cannot store much. It's a small organ, so basically it puts it into fat. It turns it into fat and stores it in the liver, and then starts spilling it outside the liver to the midsection, to the pancreas and other organs, and to ectopic fat in the spaces and in the muscle. And that is what happens to the pancreas. The pancreas starts developing fatty pancreas. The beta cells that produce insulin start differentiating. And once they do that, they are less effective in taking blood glucose out of the blood, and you become a type 2 diabetic. So that is the pathway of fructose. There's a glucose pathway. Again, half of sugar is glucose. That's the non-sweet part of sugar. And it's also in all other carbohydrates. Whenever we eat pasta, breads, uh, or any carbohydrate, it's basically a collection of glucose that breaks in the body and becomes glucose. The body hates blood glucose because blood glucose causes damage to blood vessels. That's why we have blindness, kidney disease, and others. And so the pancreas pumps a whole bunch of insulin to take the glucose out of the blood and put it into fat or turn it into energy for the cells. But if we're overeating carbohydrates over a long period of time, the body keeps pumping insulin. You develop something called hyperinsulinemia. And as we know, the body hates when you give it something over a long period of time, if exposure is too long, and it starts developing insulin resistance. So once the insulin becomes less effective, then we become type 2 diabetic. That's the pathophysiology, and this is driven by what we eat. Now, let's turn to the three main failures. So I'm going to start by giving you the difference between type 1 and type 2 and telling you that the exact opposite disease, but they share a symptom, and the symptom is high blood glucose. You can either measure high blood glucose as a HbA1c, which tells you how sugary or red blood vessels are, red blood cells are over a 3 month to 4 month period, the life cycle of a red blood cell, or you can measure it in terms of fasting blood glucose, and that'll tell you that you have high levels of blood glucose. Type 1 diabetes is the lack of endogenous insulin. For some reason, the pancreas either stops producing insulin completely or does not produce enough quality insulin. Insulin is a survivor hormone. It takes blood glucose out. I just talked about it. It needs to take the blood glucose out of the blood so it can store it, turn it into energy in cells or store it into fat. If we don't have insulin, the cells don't get the energy they need, so they die. And blood glucose goes up, so does ketone levels. So type 1 diabetics die from ketoacidosis and from high blood glucose. Type 2 diabetes is the exact opposite. It's too much endogenous insulin, too much insulin produced by the pancreas due to over consumption of carbohydrates. Insulin rises, and it takes 20 years for insulin to become insulin resistance. In these 20 years, after those 20 years, you become insulin resistant and blood glucose rises. Interestingly, to focus on this 20 years, because in these 20 years for type 2 diabetes, the body is undergoing quite a bit of damage. And that's the part that's the major failure in clinical medicine in my book, is that for 20 years, we're not looking at insulin, we're only looking at glucose. So typically in our medical approach as it is now, we only start worrying about type 2 diabetes when blood glucose goes up above a certain point. In the US, it's above 130 for fasting blood glucose, or HbA1c over 6.5. But in these 20 years, look what's happening to insulin. Insulin has been going up and up and up to keep blood glucose low. So what's happening in these 20 years? What's happening in these 20 years, and these are the PMID numbers are PubMed numbers. The paper has all the citations, but in case you don't want to read the paper, you can use those numbers from PubMed, and you can upload the papers related to the disease you're interested in. Hyperinsulinemia causes inflammation, and inflammation is associated with heart disease, strokes, obesogenic cancers. You know, the obesogenic cancers are breast, colorectal, and prostate. It also is the leading cause of for infertility for both women and men. So PCOS, polycystic ovary syndrome, and erectile dysfunction for men are also driven by hyperinsulinemia and insulin resistance. And increasingly, we're finding brain health diseases are also connected to hyperinsulinemia. So the problem with this, not identifying this, is not just a problem of not identifying diabetes early, you're not identifying these risk factors early. Fantastic book. If you want to read one book to change your life thinking about health, read a book called Why We Get Sick by Benjamin Bickman. Benjamin Bickman is a cell biologist in the US. He's Canadian, but he lives in the US. Fantastic book that links insulin resistance and all the literature that you'd need to learn how it's linked. My focus is diabetes, but in his book, he looks at all the different pieces. Now, why is this a failure? It's a failure because in the US, for example, for me, it cost me $30 to get a fasting insulin test. So I can check to see if I have insulin. In many countries, that's still not an option. But there are 15 clinically easy ways to identify symptoms, in addition to family history. So if there's any family history with diabetes, heart disease, or any metabolic disease, you increase the risk. But you look at simple things: waist for height, hypertension, uric acid levels, high triglycerides, low LDLs. These are all standard blood tests. You don't need specialized. Same thing for fatty liver disease or liver health, PCOS, skin disease, and others. And there are 7 skin diseases like skin tags, acne, early male pattern baldness, rosacea, eczema, and others. Again, the literature is there. We can identify the potential for hyperinsulinemia very early, and we can do something about it. The second big failure, I call it blaming the victim. So all the major agencies of the world that are focused on diseases, in this case, in terms of diabetes, whether it's the CDC in the US, WHO, American Diabetes Association, and other diabetes associations, all say it's a lifestyle and a food environment issue. They know that's it. Unfortunately, they give vague and sometimes wrong information. And I'm going to give you some examples. We know from what I just showed you earlier, the pathophysiology, it's about what we eat, how much carbohydrates we eat, and how often. That's the big one. It's also lack of exercise, physical activity, high levels of stress, inadequate sleep. Unfortunately, when it comes to the food environment, we tend to blame fat. Fat has zero impact on insulin, very little impact on insulin, and very little impact on blood glucose. Protein, so there are 3 macronutrients: carbohydrates, proteins, and fats. Proteins have some impact, but it's small. The big one is carbohydrates. So we tend to blame the wrong macronutrient for the disease. And this is a book I purchased a couple of years ago, and I just wanted to give you some examples. So it just broke my heart. I was reading the book and saying, I can't believe they're saying this. So on page 5, they say, eat small meals every 2 to 3 hours. Always carry a snack with you. That is horrible advice if you're a type 2 diabetic who's not using insulin. This is good advice for type 1 diabetics who are on insulin, but not for type 2 diabetics, because you're pretty much making sure somebody's going to get even worse hyperinsulinemia. The second, page 6, choose foods from the grain groups, such as air popcorn, baked tortilla chips, graham crackers, pretzels, bagels, or cereal. Every single one of these is full of carbohydrates, which breaks down into glucose very quickly, and it requires insulin from the pancreas. So these things cause diabetes. This is not the advice we should be giving people. And I want you to look at the last one, which truly broke my heart. So on page 19, they say, and this is by two nutritionists who are certified by the American Diabetes Association, and the book is endorsed by the American Diabetes Association. So on page 19, it says, research has shown that sugar is okay for people with diabetes if it is a part of a meal plan. Oh my God, is this wrong? Sugar is the main driver of diabetes. It's as if you can tell a alcoholic, it's okay to drink alcohol, but just drink it while you're eating food. No, it's not. And so it's shocking how much bad advice has been given on this. Even the CDC, the Centers for Disease Control, which is seen globally as a leader, I downloaded a year ago their main document. It's a 53-page document that encourages development of programs, community programs for prevention. And I looked at it and I read it and I read it and I read it. It offers no specific details about the types of interventions. It talks in generic terms. And it only mentions food once, and it says you need to lower the amount of fat you eat. Zero reference about the actual drivers of type 2 diabetes. How can that be? How can these agencies completely miss the most important part of this disease? Shocking. WHO has also failed, and their quotations around non-pharmaceutical approaches, they talk about a healthy diet. What's a healthy diet? You need to be specific for type 2 diabetics. What is the driver? They talk about a balanced diet. What's a balanced diet? Balanced of what? It's crazy that they don't have specifics, that the literature tells us what drives type 2 diabetes. The third failure, and I'm almost done here, is we actually finance the disease. So basically, those of us who worked in public health as long as I have, we always think of taxing tobacco as that big, big win in public health by looking outside the health sector. The reason it worked is when you tax a product, you increase its price. When you increase its price, it lowers demand. Basic economics. A subsidy is the exact opposite. If you lower a price, you increase the use. Every country I've looked at subsidizes carbohydrates, whether it's sugar, corn, or flour, usually breads, and rice in many places. So we basically are failing the population because we subsidize the cause of disease that's becoming a pretty big problem. Can we change that? We tend to say we do this because we want to help the poor by subsidizing staple foods, but we do that by actually increasing the disease risk of the population. And it's not a very well targeted program. Can we do better? Can we think of pro-poor policies and instruments that are not pro-disease? And yes, there's quite a bit of evidence, not in health, in social protection and in other sectors where this can be done. The ADB can do a lot here. So there's a lot of failures. There's a few islands of success and a lot of failures. From the successes which we have in the paper, we distill it into a set of things that we can do differently. How we support countries' health systems, changing how resources are allocated towards early detection, using incentives through provider payment systems, through insurance and other financiers, changing the clinical guidelines for early detection and management. We can change the subsidies, and we can strengthen the information environment, as well as supporting the communities of type 2 diabetes and leverage technology. There's a lot more on this that I'm working on in the next set of papers, so I'm not going to spend too much time on it here. Can we do better? Yes, we can. We can do a lot better. In the paper that's upcoming on development assistance and health, we talk about first, do no harm. So change the things that are causing damage, how we transform the health system to do what we needed to do, and how we work outside the health system through tax policy. And we also map out different lending instruments. What can you do with results-based financing, policy-based financing, input-based financing, even knowledge products. So we try to focus on what, and the authors are people who've worked in the Inter-American Development Bank as well as the World Bank. So it'll be quite relevant, I think, for the ADB as well. That's it.
Thank you, Abdo, for that very informative presentation. So we'll now open the floor for a couple of questions. Just raise your hand if you have any questions. Anyone? Doc, do you want to ask a question? Jingmin? Yes. You can unmute yourself, please.
Thank you very much, Dr. Abdul. Very informative and really very timely introduction and detailed about this type 2 diabetes. I'm working on water and urban development sector. In our sector, in fact, we are promoting this urban agriculture, means that to encourage people to grow some vegetables. So in all these different approaches to prevent this type 2 diabetes, can you explain us a bit more, how these fruits and vegetables balance should be managed in their diet?
Sure.
So, when we promote our incentives on this urban agriculture to grow some vegetables, because in most areas it's not so convenient to get vegetables, in many countries, specifically in these island countries. So
yes.
Thank you. Very good. Thank you so much. I learned a lot.
You're welcome. I appreciate the question and the comment. Yes. So basically, not all fruits are bad. Some fruits are worse than others. So berries and a few other fruits are actually not that bad for diabetics because they have a very low glycemic load. So there's a whole literature about the glycemic load, and that's something you need to keep an eye on. Vegetables, yes, it's important to understand most vegetables are okay because they have a high percentage of very low percentage of sugar relative to other macronutrients. But for vegetables that are grown underground, potatoes and a few others with high glycemic load, those can become a problem. And so it's important when you think about agricultural policy to recognize, especially if you're working in the Pacific or in some places where, like the Middle East, where type 2 diabetes is like a large percentage of the population, then we need to think creatively. Now, there are other important things to do that have nothing to do with agriculture. So processed food is a terrible idea. Shelf space food. So how do you keep food on a shelf how do you keep it from rotting? You take out two things. You take out the fat and you take out the fiber. And you make it worse for people. So there are other food related policies that can be influenced, not just change but yes, I think it's important to work on that. Thank you.
Yeah, sure.
Yes. Hi, Abdul. Nice to hear your talk. My name is Yeshu. I'm Senior Health Specialist based in Jakarta. And I think that we overlapped a little bit when I was doing my consulting job at the World Bank. So very nice to see you again. Thank you for your talk because I think this topic is also very dear to my heart. I think as an individual, as you start to age, obviously you start to pay attention to nutrition issues. Even as a health specialist, I think there is still a lack of systematic information about how we do balanced diet. So that point that you brought up, that there is a failure in terms of lack of specific nutrition or diet, and recommendations, even from the leading technical agencies, is really a key challenge even for public health professionals to promote this agenda of balanced diet. And we know, as a Chinese and in many cultures around the world, we know that food is medicine. I think in the US now, there is also this movement about promoting food as the medicine and promoting, lifestyle medicine and functional medicine. So really, I think health is really about preventing disease and health promotion. So I'd like to share that in ADB, we are also starting to do more cross-sectoral work, looking at the intersection of agriculture production and, as Jingming shared, urban and water investment, and also public health. So in Indonesia, we are, trying to start a pilot looking at through a school meals delivery program to look at how we can, integrate a lot of the, nutrition education to younger children at school so that they start building those healthy diet habits from early on. But there is a lot more to do. So maybe my question to you is, for this specific recommendations from, ADB and other technical agencies, how we can work with, WHO and other agencies on this. We also know that there is tendency to say that each individual may need a customized solution. So how to balance that kind of individuality and a general good nutrition recommendations? Yeah, thank you.
Thank you. Very good question. Very difficult question. Good luck working with WHO on this, because they refuse to provide the actual technical advice. They use generic terms. Balanced diet. What's balanced? Now, on your point about different reactions by different individuals, absolutely, 100%. With one caveat. I showed you that chart on how different macronutrients impact insulin. That chart applies to every human being, except it applies slightly differently in the curve. So the general direction is the same for everybody. It's just that different people respond differently to the food. So give you an example. We are now finding, so it used to be assumed that the main driver of type 2 diabetes is obesity. That is not the case if you are from Asia. If you're from Asia, most people who become diabetics are not obese. They are what's called TOFI, thin on the outside, fat on the inside. It's about fat accumulation in the visceral part of the body. And so there are genetic drivers for how different people react differently to foods. But the main message that this is a nutritional disease driven predominantly by carbohydrates applies to everybody. It just applies differently across genetic population. It also applies differently across individuals. So in my case, I'll be honest with everybody, both of my parents were diabetics. Two of my grandparents were diabetics, and I became a diabetic 16 years ago. And it took me 10 years to figure it out. So this is very personal for me. And so a lot of the research I did as a patient. And then once I realized there's this huge failure, I wanted to make a difference. But yes, it's absolutely critical that we get the message out. There are some variability. Now, the way I solve the variability question is I put every individual in charge of their own measurement, biofeedback. So there's a simple thing called a prick test. Any type 2 diabetic or pre-diabetic, it's very simple. And now it's even easier because there's something called CGM, continuous glucose meter. So if you want to test what works for you, you get 2 weeks worth of a continuous glucose meter and simply take pictures of everything you eat and the time you eat it and see how your body reacts to it. What you'll find when we do that for large population numbers is they move all in the same direction, but at different curvatures. So for some people, eating rice affects them much worse than other people, but they all get a spike. It's just it's a different spike. So I've spoken too much. I'm sorry, but this is very close to my heart. Thank you.
Thank you.
Thank you, Abdo. So one last question before we go into the next presentation. Aki?
Thank you very much. This is Akihito Watanabe from the health team as well. It was very interesting presentation, and I used to work in the virtual, not in the NCD team. I just wanted to ask you that you mentioned that the CDC or the VHO's recommendations and guidance are vague or sometimes in not directly ideal recommendations for the type 2 diabetes. But I'm sure they have a reason that they keep it vague or different recommendations. What's your assessment on this? Because they are targeting different audience, or they have a more balanced recommendation, or I don't know, with pressure from the industry. So I'm sure they have some reasons not doing that message that producing the idea for the private side diabetes.
I would love to know why they don't use the actual data. Because again, I'm not a physician. I've gotten to know this disease because it's my disease and I've invested 10 years of learning about it myself. But it was shocking. So when we got this paper published, I had 3 endocrinologists provide feedback because I was worried. I'm not a physician. One of my co-authors is a physician. And I wanted to understand from them, why is this not common knowledge? And I honestly couldn't get a direct answer. The most direct answer I got, and it was a very negative one, it was one of the peer reviewers said, us doctors, we keep telling people they need to change their behavior and they fail to do so. So I asked, okay, so I'm a diabetic. When I became a diabetic, the nutritionist told me I need to lose weight. The nutritionist told me, don't eat white bread, eat brown bread. Not good. The nutritionist told me you can have some rice, eat 6 times a day. So this whole thing that people don't change their behavior, that's why the second failure is we communicate incorrectly. Now, your question is why? Why is there this failure? And I have no idea. Is it that I can tell you that, for example, the only group I'm quite sure is corrupt is the American Diabetes Association. And I can tell you why they're corrupt, because I was a member for quite a long time, and I used to get their magazines. Their magazines are full of advertisements, very expensive advertisements for 2 groups, food industry and pharmaceutical industry. Neither group has any incentive to get us healthy, I'm sorry to say. So for at least that group, there's a corruption element. For the CDC, for WHO, I have no idea. It just frustrates the hell out of me that they don't provide the correct information. And, because I have a PhD in health statistics, I can read the literature, and the literature is quite clear, except these large associations, for some reason, don't provide it. I don't know why.
Thank you,
Yeah,
Abdo. So
thank you
before we
very
go
much. Yeah.
into, yeah, thanks, Aki. Before we go into the next presentation, a few words from Doc Dodo.
Yeah, thank you, Abdo. So sorry, I was with Agnes last week in the Paris Nutrition for Growth meeting, and I think some of the points you asked were points that we actually discussed. Just before we have the presentation from PhilHealth, it will be quite interesting because we talk about multi-sectoral because nutrition is a priority of ADB. And that in a sense that when we start talking about actions addressing nutrition, it's not just going to be the traditional concerns, which is of course acute malnutrition and stunting, but obesity. And as what Abdo was saying, in Asia, I love this, thin in the outside, fat on the inside, right? Not because I am big, but because it also highlights that beyond obesity, if 15% of healthcare causes diabetes, ADB should be taking action as well. So hopefully, Abdo, as you progress, and I would really like you to listen to what Philippines is trying to do with their health insurance, is that you could also you and Luisa could also ask us in ADB to come in and join you, and we look forward to, in a sense, I may need to leave before this meeting is over, this webinar is over, we could do some collaborative work, future papers that we could actually explore. We now have an Asian lens. So please tell Luisa, we look forward to have. Now, Abdo,
Just
and then we'll
one
have.
quick thing, Dodo. I just want to motivate you. You cover the two of the three hotspots for diabetes in the world. You cover Pacific, which is the worst, and the GCC states of the Middle East, which is the third worst. The second worst is Caribbean. And so there's a huge motivation for the ADB to do work on diabetes, and I would love to work with you on that if that opportunity is open. And I have a lot of papers I'm writing, so I'm happy to send them to you if you're interested in collaborating on this.
The Pacific for sure. Unfortunately, GCC is not with us. Uh,
Oh,
but I do know that GCC uh, is a hotspot in diabetes as well. But I think us trying to help fix Pacific, the diabetes problem there would be, I think, really very would be a big task already ahead of us. But nonetheless, and looking forward, we'll be reaching out. Uh, so our next speaker, Mitchell, let me just do this, will be from the Philippine Health Insurance Corporation. Of course, ADB has been supporting UHC reforms in lots of developing member countries. That means we support both ministries of health and PhilHealth. So we've asked Mel, who's in charge of benefits, to listen to the presentation. And she'll be talking about what PhilHealth is trying to do with regards to diabetes. But more than that, we hope that Mel, this could be start of a further dialogue, and not just with Philippines, but also with other DMCs on how we could help the financing decisions on the financing decisions so that it can actually be much more responsive in addressing, in controlling, preventing, and controlling diabetes. Mitch, the floor is to you.
Yes.
Mel?
Yes. Good morning, everyone. So we will be sharing how Philippines and the Philippine Health Insurance Corporation provides coverage for treatment related for diabetes related treatments. So this is the content of the presentation. We have I'll just share with you very quickly the legal basis of the national health insurance and the universal health care. Some background on what the diseases of Filipinos are, and walk you through the coverage for diabetes-related treatments, show you a snapshot of the utilization for these treatments and future directions of PhilHealth. So in the Philippine healthcare system, we have two important laws. We have the National Health Insurance Act, which established the National Health Insurance Program to provide responsive benefit packages, as well as improve these benefit packages to meet the needs of its members. So it is according to the needs of the population. This law also established the Philippine Health Insurance Corporation as the administrator of the National Health Insurance Program. So in general, PhilHealth accredits healthcare providers. It develops benefits packages, and it's also the agency that reimburses these healthcare providers for the services they deliver to PhilHealth members. The second law is the Universal Healthcare Act. So this law states that PhilHealth shall be the national strategic purchaser of individual health goods and services, ensuring equitable access to these services without causing financial hardship. Now, so we have the universal healthcare law. It is a whole of system, whole of government, and whole of society approach, where all Filipinos are covered by social health insurance. So we are here in PhilHealth to expand and improve benefits coverage, to design an explicit health benefits package, to develop the yearly benefit plan of the corporation, and to review the health benefit package periodically. And we follow certain criteria for health benefits package prioritization, so according to need. The first one is we would like to understand what Filipinos are dying of and what Filipinos are getting sick of. So we'll look at the burden of disease and other epidemiologic data. The next is financial risk protection with equity consideration. So when we develop a benefit package or expand existing benefit packages, we would like to ensure that the services are available to Filipinos wherever they are in the Philippines, available, affordable, and accessible. The Philippines is an archipelago, and there are geographically isolated and disadvantaged areas. So we want to ensure that these services are always available and accessible to Filipinos. In the Universal Healthcare Law, there is a provision that any planned service coverage of the Philippine Health Insurance Corporation or even the Department of Health, there should be a positive recommendation of the Health Technology Assessment Council. So if there is an introduction of a new technology, for example, a new drug, it has to go through HTA. We also have other considerations that our benefit packages should be anchored on the Sustainable Development Goals, the Philippine Development Plan, the National Objectives for Health. In the Philippines, we have legislative mandates. We've put into law some of these diseases. We have Mental Health Act. We have the National Integrated Cancer Control Act. We have the Magna Carta for persons with disabilities, even the Rare Disease Act, and also consideration, of course, of public interest. Very quickly, we'd like to show you the how we looked at the Philippine burden of disease. So this is as of 2021. In the blue bars, these are the non-communicable diseases. So we actually identified what we call the vital few, which consists of the 20% of the diseases, accounting for 80% of the DALIs. So these 20% diseases are 35 all in all. And we see here in vertical arrows, this one is diabetes mellitus. It's fifth. And as we heard from Dr. Yazbeck, that complications of diabetes could encompass heart diseases, stroke, chronic kidney diseases, and hypertensive cardiovascular diseases. And here, diabetes mellitus is in the top 10. And the top 10 diseases in the Philippines already account for 47% of the DALIs. And among the risk factors contributing to this disease, as we've heard, it's dietary risk. So we see here high fasting plasma glucose, kidney dysfunction, and other dietary risks. And from the 5 years ago, 2016, and now and the data we have 2021, we have diabetes that has risen up in ranking from number 8 to number 7. Now, unlike other ASEAN countries, the life expectancy at birth in the Philippines did not change from 1990 to 2021. So we'd like to understand why. So here, looking at the Philippine burden of disease in 2021, we've identified 35 diseases accounting for 80% of the DALIs. Diabetes is among the top 10 diseases that already contribute to almost half of the total DALIs. And of course, complications of diabetes like heart disease, stroke, remain the leading causes of disease burden in the Philippines. And also, the life expectancy did not improve for the past 2 decades, and we've identified dietary risks among the top 5 risk factors, and notable increases in the rankings of diabetes occurring in the past 5 years from 2016 to 2021. Now, let me walk you through now to the coverage of PhilHealth for diabetes-related treatments and complications of diabetes. So top in the list, but this is a very new benefit of PhilHealth. It's the Consulta benefit package. So this is a primary care coverage for services in the primary care. We have inpatient benefits for diabetes-related treatment. For example, for diabetic ketoacidosis, for complications of diabetes like ischemic heart disease, acute myocardial infarction, uh, inpatient benefit package for acute stroke, even renal replacement therapy that covers the spectrum from hemodialysis, peritoneal dialysis, kidney transplantation, and even post-kidney transplantation services. We have emergency benefit package to cover cases of hypertensive emergency and also coverage for certain procedures related to diabetes treatment, such as debridement, amputation for diabetic foot, vitrectomy for diabetic retinopathy. So for primary care, this includes consultation, health risk assessment, screening, selected laboratory and diagnostic tests, and selected drugs and medicines. So listening to the lecture of Mr. Yazbeck, we'd like to maybe improve the way we do the counseling for diabetes. Now, for myocardial infarction, so it's downstream coverage for these services, which are very expensive, such as percutaneous coronary intervention, fibrinolysis. So those are very expensive services that we cover. And hemodialysis, it's almost 1 million per Filipino per year, every year that we cover for hemodialysis. And for peritoneal dialysis, the same. We cover both in adults and in children. And in children, we even have coverage for automated peritoneal dialysis. And coverage for kidney transplantation that covers the pre-transplantation workup of both the recipient and donor. The surgery that includes the donor nephrectomy for the living organ donor. You see, in the Philippines, unlike in other countries, we actually have more living organ donors for kidney transplantation compared with diseased organ donor transplantation, as well as post-transplantation services that are covered. That includes very expensive immunosuppressive medicines. For this post-KT service coverage, the cost driver is really the drugs and the medicines. For the laboratory and diagnostic tests, there's coverage again for the monitoring for diabetic patients. Now, this is just a snapshot of a utilization for diabetic ketoacidosis. We see that comparing last year, 2 years ago, and last year, with increasing reimbursements for all types of DKA because of IDDM or NIDDM or other related conditions leading to DKA. So increasing reimbursements for these services, treatments, and for the complications of diabetes, see we have increasing reimbursements also for consults for hypertensive emergency, doubling, and stroke, as well as hemodialysis, which is our #1 procedure claimed in the social health insurance in the Philippines. So in terms of future direction for diabetes and other NCDs, our current administration is looking into the following: prioritizing primary healthcare prevention, expanding the Consulta benefit package to a comprehensive outpatient benefit package, Second is adopting a broader framework that integrates the health needs, disease burden, equity, stakeholder values, and cost effectiveness data. So, with this, we have an internal policy which we call the PhilHealth Benefits Development Planning Protocol that we follow to anchor the values of to this broader framework. And thirdly, to use the provider payment mechanisms listed in the Universal Healthcare Law, as well as strategic purchasing to influence healthcare provider practice and the health seeking behavior of PhilHealth members. And finally, a robust stakeholder engagement and communications. So that's the end of the presentation. Thank you very much. So that is what we have in terms of diabetes related treatment service coverage in the Philippines.
Thank you, Dr. Santillan. So, Abdo, would you have any comments, or I guess because from Dr. Santillan's presentation, we could see the burden actually of diabetes on the insurance system of the Philippines. Would you have any, I guess, reaction on how they could improve the coverage to better address diabetes?
Thank you for the wonderful presentation. Clearly, I had not seen any documents and I had not seen the presentation before, so I would be a bad practitioner of development assistance if I provided inputs into something I haven't really studied very carefully. But what I see is incredible opportunities. All the required organizational and instrumental things that could be done to improve the response is there. Um, Things such as having a health technology assessment mechanism, things like defining a benefits package, thinking about earlier intervention, earlier detection, all the pieces, even using provider payment mechanisms. So there's a lot of the correct pieces there. I think a focused effort to address the what I see as the three main failures, which are global in nature, not Philippine specific. It's happening in every country. Could produce very positive results, and the Philippines has all the mechanisms and all the tools to do that. So I'm very positive. I think there's incredible opportunity to make a big difference in this disease, which is, as the burden of disease shows, is a huge driver in the country. I was also surprised to see the lack of improvements in life expectancy compared to other Asian countries. That is quite concerning. And I don't know enough about the country to know, is that driven by non-communicable diseases or which specific elements of non-communicable diseases compared to other countries. I mean, if I were a researcher working in the Philippines, I would like to dig deep into that and see to what extent this is driven by limitations in addressing early enough things. So type 2 diabetes, like any other NCD, the earlier you get into it at the lowest level of care, the better outcomes you're going to get. Once you get to the stage where we have amputations or kidney failure or heart disease, the outcomes, the cost effectiveness of medicine becomes quite low. So the policy answer is early, 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 the earlier possible identification. So good luck.
Dr. Mel? So I guess the question will be, I guess is PhilHealth open to maybe revising some policies? Because from Abdul's presentation, he was on the early detection, and it will be that part of I guess the consulta package is just being rolled out like, in the first few years of being rolled out. Is this something that PhilHealth is considering?
Yes, actually, in the benefits development planning protocol, there is a step where we can revisit the policies that we've already implemented to review the standards, to engage stakeholders, to look at the implementation as well as to study the impact of the benefit package 5 years after implementation. So definitely yes, the Philippines is always open to improving how we deliver services, public health services. Yes.
Thank you, Doc Mel. I guess this so that wraps up for today's webinar. I think there are opportunities for further discussions between ADB and our partners. So if there are any more questions, we will close now the webinar, and we hope to see you again in our next NCD talk. And if you have any more questions, just send it to us, and then we will forward it to Abdo and Dr. Mel. Thank you, everyone. Have a nice day.